Welcome to the APAP podcast. My name is Rhea Votipka. I'm a nurse practitioner in Burlington, Massachusetts at Leahy Hospital, where I work in the pulmonary and critical care department in the medical ICU, as well as teach focus for the University of Massachusetts Chan at Leahy Hospital. I'm also the current chair of the Critical Care Committee and the president-elect for the 2026-2027 year. And today our podcast is hosted by the Critical Care Committee. And we're so thankful that you guys are here to join us today. The goal of this podcast is really to prep anyone who is interested in working in an ICU. Maybe you are an APP fellow and you're starting out in an ICU, or you're a med student, APP student, or any kind of student that is doing a rotation in the ICU. It can be difficult to know where to start because critical care can be so broad. I would also say this podcast can be very helpful for those who are educating those in those learner roles to give you a foundation and maybe an outline for how best to train them and prepare them for their work in an ICU. We're going to be focusing on how to present yourself when you're there, how to prepare as far as which guidelines to read, maybe what topics you should be aware of, and even more nuanced things that you won't learn in a classroom, like maybe how to interact with consultants or the attendings that you're working with. So that's really the goal of this podcast. And I'm really thankful to have two experts on this topic. I have Mike Plourde and Kirsten Lorenz, and they are chairs of APP fellowship programs in two different areas. So now I'd love for you to hear from them and kind of hear a little bit about themselves, so that you can kind of get an idea of where they're coming from and how they are very passionate about this particular topic. We're going to start with one of my colleagues, Mike Plourde, who actually works at Leahy with me, and he is now the chair of the APP Fellowship Program. So Mike, thank you so much for joining us.
It's great to be here. I'm excited. So like saying, I was been the director of our critical care fellowship going on almost 3 years. The fellowship itself at Leahy has existed for, I think, close to 9 or 10. So it's fairly established, but it's changed quite a bit since then. And so I think it's a great learning situation for anyone who's new to critical care to consider doing a fellowship.
Right. And not only have you been the director for 3 years, but you've also been an active participant in the education in the many years prior to that. So you do have definitely a lot more experience in dealing with, or not dealing with, but working with those in the student role.
Oh, just that the having a lot of experience with that helps. And I was in charge of sort of the students and rotations before that. And so building on all of that, there's a lot of similarities. So.
Absolutely. And Kirsten is one of the members of APAP. She's been involved leading Journal Club. She's also presented at the APAP National Conference. And she's based at Prisma Health in Greenville, South Carolina. So Kirsten, thank you so much for being here. Can you tell us a bit about yourself?
Yeah, thank you for having me, Rhea. So yes, my name's Kirsten Lorenz. I've been practicing in the pulmonary critical care specialty since around 2016. I actually started in pulmonary critical care, working mostly in a medical ICU as a new graduate myself. So I had not had the opportunity to go through a fellowship at the time, so I can really relate to, I think, this topic, and I'm passionate about it. But fast forward to now, I've been working with Prisma Health in Greenville, South Carolina since 2019, and we've kind of built upon our critical care APP program. And with that, also started a critical care APP fellowship. So we're finishing up our third cohort of the program, starting the 4th in January, and very excited. And Mike, as you're saying, it's a little bit newer, less established, but it's always ever changing and growing and hopefully just continuing to improve. So we love it, but very passionate about not only new providers such as fellows in the ICU, but again, any student, any new learner, or even a new graduate that is looking to go straight into the ICU. And so excited to talk to everyone about that now.
Great. So I'm just going to go ahead and we'll start kind of launching into some questions. But before we get to the more knowledge-based clinical questions, I wanted to first start off with talking about the key characteristics that you're looking for, or maybe the attitudes that you find are most successful when somebody is starting off through an ICU rotation. Kirsten, do you mind just kind of giving us a little feedback on that?
Yeah, I tried to kind of break these down into different buckets, and I wanted to kind of expand upon just a few examples. But I think for me, the first one is being honest and transparent. So, number one, with yourself about what your perceived strengths and weaknesses are, but then also being honest and having a higher integrity about if you have near misses or mistakes. So, I think that I would put as probably the highest. But right below that, I think having a characteristic of humility. It's really important. Obviously, the IC is a very humbling environment. You're never going to know everything. It's a very steep learning curve. So going into it with that type of, eager to learn, eager to know, but being also self-aware, it's not expected that you know everything right now. It'll continue to keep you humble as you do grow throughout your career. And that factors into knowing when you've reached your personal limits and you need to ask for help. And I think that that's really important, not only for new providers, but anyone working in an ICU environment. Teamwork and collaboration are really important as well. I would say that's my third kind of bucket for characteristics. And the ICU is a team sport. And so this goes not only to your fellow colleagues regarding physicians, APPs, but our nurses are awesome. They know the most really about the patient on the day in and day out basis. They're great for continuity. Respiratory therapists, ECMO specialists, anyone that you may be working with, I think really lean into them and be willing and keen on fostering that collaborative teamwork environment. Next, I would say flexibility and being resilient. The one constant thing is healthcare is change, and especially in critical care. And so, give yourself a little grace and know that, things might be done this way one day, and then there's new and better practices moving forward, and be aware of that and stay humble enough to keep up with it, and resilient to endure all of those changes, of course. And I would say last is maintain a positive attitude as much as you can. Obviously, it's a tough environment, not only physically, emotionally, mentally, but know that you're doing really important and strong work and can really positively impact families and patients themselves. And try to maintain that environment and mindset for yourself while you're going through all of it as well.
Definitely. I completely agree with all those. And I would say that they are really applicable to anybody working in the ICU, because no matter how long I've been
Absolutely.
there, no matter how long I'm there, there's always something that I haven't seen before that I don't know. And even people who are maybe younger in their career than me, sometimes they know too. And so you really have to maintain that humble attitude. And really the best thing that we can do for our patients is work with our colleagues so that we can really have that better outcome for them. Mike, do you have any additional thoughts on kind of those attitudes and what do you think is going to help somebody be really successful in the ICU?
Yeah, I agree absolutely with everything you said. I'll echo the humility. And I think because especially as APPs, a lot of people coming into this space are sometimes it's a second career. Certainly with nurse practitioners, everyone was a nurse beforehand. A lot of PAs have prior experience, often in like EMS or as MAs or something like that. And I think there's a really fine line of applying your previous experience, but you also have to kind of be ready to kind of toss it out the window and say, this is a new thing that I know a little bit about, and realizing that you know a little bit about it, but you have still a lot to learn, is really, really important. I would say being genuinely, like it sounds kind of obvious, genuinely interested and ambitious in critical care. And so when we interview people for our fellowship, it's kind of very obvious who is just looking like, oh, I did, hospital medicine and I didn't really like that. So now I want to do something new, and I kind of critical care seems cool. And so I'm going to try this, versus the people who are like, I went to PA school because I want to work in an ICU and I want to do all of these invasive procedures and try and save lives and do of those things. And so having that inherent, like, just love really of critical care is important. And I think that that adds to what you were saying, Kristen, the resiliency. Like, if you didn't love this, you really couldn't do it because it is really, really hard. And so if you don't have that sort of passion and ambition for it, then it's going to be a lot harder. And it's obvious kind of to those around you too, that if you're sort of there just to do it versus it's a true passion.
Definitely. And I know that we have seen that before. But for some people, maybe more so the student who are not interested in critical care, you can still have that same like willingness to learn, and maybe critical care isn't your passion, but really having that attitude of just being willing to learn, because again, critical care is so broad. There's going to be things that will be applicable to really any field that you go in. And just having that attitude, I personally, especially when it comes to students, I don't care so much about the exact knowledge base that they have, but rather I most care about, are they at least willing to learn, at least willing to kind of process what they're seeing, critically think, because critical thinking isn't just used for ICU.
Yeah, and really applicable to like life in general. I feel like there's a lot of ways that we even think about things and talk about things that are applicable to other areas of medicine, but just life.
Definitely. Now, Mike, what about, we talked a lot about the attitudes that we love to see, and kind of the how you can show up ready to be on the unit and work with other people. What about things that might get in the way of successful rotation, or get in the way of a successful career in ICU?
Yeah, I mean, that's really important too. I think it's going to be sort of like the opposite that we talked about, right? So if you're coming in and you're overconfident and you said, oh, well, I've been a ED tech for 10 years, and so, or I've been a paramedic for whatever, and I already know all of this. And that sort of goes hand in hand with like, well, I don't need to learn anything because I've already done all this. I'm really just here for a piece of paper or for a grade, to say that I did this, even though I already knew that I can. And I think that it's really dangerous, obviously for patients and for everyone else involved. And it tends to rub your preceptors and people who are going to be teaching you and supervising you the wrong way. And so if you're someone that is sort of not pleasant to hang out with, in the call room or whatever, then I'm probably going to be less likely to be, hey, let's go see this consult, or do you want to help me with this line, and that sort of thing. And I think there also has to be a little bit of a line, and I don't love the term professionalism, but I think there's some temptation for students and learners to almost try to become too friendly with preceptors and that sort of thing. And I think you should be cordial, and it's okay to be a little bit friendly, but you're there to learn how to take care of patients, and especially in the ICU, that's an awesome responsibility. And so if you're trying to make jokes about, we talk about gallows humors and that sort of thing, as a student or a learner, I would try to stay away from that, because you don't really have the experience and things to say those things that sometimes you'll hear. And it's tempting to like, oh, I want to fit in and I get this, and so I'm going to make a joke about it. But if it can oftentimes land flat and make a very awkward situation.
Yeah. That's a really good point. I've seen that before too, and I didn't have that when I was kind of brainstorming about a few of these topics, but it is a really, really good point, is maintaining the kind of, I'm here, for a very intentional reason to learn from the people who are doing this day in and day out, and be serious about it. And also, I think that shows that you're respectful of their time, their efforts, and what they're putting into trying to help educate you is always really important. So yeah, the only other thing that I would add is, of course, not having some of the characteristics you already talked about that will help you be successful. One thing that I would also recommend is, if you're starting a career in critical care, and it's not more so just a rotation. That is going to be almost a forever home for you. I would caution just to be aware, don't take clinical outcomes that may not be desired as personal failures. And I think that's easy to do. I myself know that as a new grad, I did not go through a fellowship. I had awesome APPs and physicians who supported me when I started back in 2016. And they were great. We just also, I think I was naive to the high volume, high acuity environment that I was walking into. Despite being peripherally familiar, I was assuming a new role. And I think it's very easy for new providers to take outcomes that are not what you hoped, not what you desired. You were, to do everything to prevent X, Y, and Z from happening as a personal failure. And that is really, really key to be mindful of so that you don't have burnout or emotional fatigue that's above and beyond what is a healthy level of reflection whenever something, doesn't go your way clinically. And so that would be one thing that I would add. Don't interpret those things as personal failures. Debrief, have mentors, talk with your colleagues. Of course, be honest with yourself and assess, wow, did I miss something? And I think that'll only make you better. But in this scenario, more than the majority of the time, it's just that was a really sick scenario, sick patient. We did everything. And reflect on that, but don't take it personally.
Yeah, that self-reflection is something that we should say is part of something that we look for, because that is really, really hard to do, and something that you kind of have to cultivate. And so being able to say, even like maybe I did miss something and I did make a mistake, and here's what led me to do this, and here's what I can do differently next time is super important. And being able to sometimes just say, sometimes things don't work out. It's hard.
Absolutely. And again, these are always all things that are not just applicable when you're starting out. They might be more common when you're starting out, but I think this is something that happens throughout your career, and that will make your whole career successful for sure. So we're going to take a little bit of a turn now and focus more on the information that someone coming to the ICU, key guideline that you suggest for patients starting off, not patients, for providers and our students starting off in an ICU. And this is mostly just to say, hey, this will help you be familiar with what you're doing. This will help you in processing how you're going to do interventions and make sure that what you're doing is evidence-based. What kind of articles or guidelines that you recommend for those starting off in the ICU? Kirsten, do you want to start off with that one?
Yeah, I'll cover a few topics that, are very common. Again, I practice in a medical ICU and then in a CV ICU. Our whole team kind of rotates on, kind of I'll split that workload. So it's about 50-50. And so again, I will say that I would be more naive and not experiencing a surgical or of a neuro critical care environment. So I'm going to preface that. But I kind of break it down by our biggest diagnoses and things that we see. So for ARDS or ARDS, I would definitely want everyone to just be familiar if you're coming into that environment with the ARMA trial that started low tidal volume, really cemented it. ProSiva is another really important trial as to why we prone, what is the mortality benefit, who qualifies, when do we do it, when do we stop doing it. So ARMA, ProSiva, and then the third trial for ARDS is just be familiar with DEXA ARDS. That would be my recommendation. And so not that encompasses everything we do when we treat ARDS patients, but it gives you a really, really good foundation, I think, about the data behind the why. And who qualifies for it, pluses and minuses of each of those trials. And then second, before I let Mike go, I have a few things that I would recommend, but I don't want to steal anyone's thunder or anything. There's so much as you're well, it would be overwhelming, but for ARDS, those would be my three. And then sepsis is also still ever evolving, but being familiar with your sepsis 3 guidelines from JAMA, and those will probably be updated soon. But I'll hand it over to you, Mike. I have a few other recommendations depending on where folks are practicing, but it is broad.
Yeah, it's funny. I wrote down the exact same things as you for SIVA and ArtsNet, and then surviving
Which
sepsis.
is a
So I'll
good
add. I
thing,
mean,
because
that's bread and butter, right?
yeah,
If you don't
exactly.
know that, then you're gonna be, yeah. I'll add. I think the guidelines for sedation and analgesia in ICU, SCCM, getting into the A, B, C, D, E, F bundle. I think especially as a learner, you should have an idea that if you're going into the ICU, I should know what sepsis is and how to treat it. I should probably have a little bit of an idea about ARDS. I know, again, I started as a new grad as well. And in school, we learned nothing about sedation, agitation, delirium. I had no idea what delirium was. I certainly had a very abstract textbook idea of it. Until you see it, it's really, really hard to kind of realize it. And then realizing how important those things are and how much they affect outcomes as much as anything else that we've discussed, right? And so I think a lot of students don't have that. So if you go into a rotation or start a fellowship and you're already really in on the pain, sedation, agitation, delirium literature, like I would be pretty impressed by that.
No, you're right. And then that's from first morning walking into the ICU after your report, having to deal with the pain, sedation, and delirium, probably before you even recognize sepsis, as you're alluding to. Very common.
Yeah. And then, oh, sorry.
No, go for it. I agree.
I was just going to add there's the literature. I'm blanking on the trials about like vasopressors, the norepinephrine versus dopamine, obviously a long time ago, and norepinephrine plus vasopressin. Those are sort of bread and butter things that someone will probably tell you should, like on your first day or whatever. If you haven't read those, you should. But if you already know it, then you're getting off on the right.
Yeah, I agree. And then the other thing I would add that is also just really important is your pulmonary embolism guidelines. So, 1 PE doesn't equal all PEs, and there's different varieties. And so I think at least taking a look at chests, VTE guidelines, and then I also referenced the European Society of Cardiology guidelines in 2019, and they mirror chests pretty well as well. But they have really good graphics charts. Both of them do, that are quick. I have a folder in my photos album for my phone where I just do screenshots of a lot of really important guidelines or charts, or how do I classify this, different characteristics, lab work, so on and so forth. So I recommend doing that.
That's a great.
But
I should do that.
yeah, so I have. It's called, it's for keep it simple, especially at 3 a.m. when your brain's not functioning at a high level. But I have a work resources album with my photos that I will screenshot. And I'll share that with colleagues and learners, because it's like, don't memorize things that you don't 100% have to. You're going to memorize a ton of other things, but at least have the resource available really, really, really quickly. So I would say PE, those are the guidelines, chess and European Society of Cardiology. And then the only other recommendation is not a guideline, but be aware what gram positives, gram negatives, anaerobic coverage, is on formulary based off of where you're practicing, and antibiograms, it doesn't even cover that bug quite well in our institution. That's going to vary. And so you can't go wrong with at least being familiar with how to cover, depending on what source you're thinking from a sepsis perspective too.
Kirsten, I think you bring up a really good point. And I'm like you on my work phone. There are references that I have, and that is okay. And I think that should be known, but being aware that you need to go look something up, that's the key, right? But I do that all the time. Probably I have it as a favorite in my phone is what is 6 mg per kg paddle volume to 8 mg per kg paddle volume for female and male patients. I mean, I don't memorize that stuff, but I know I need to look at it, and I know why it's important. And so having those resources at your fingertips is really helpful. What about any other, we talked some about key guidelines, and we don't want to overwhelm people that are maybe starting off. But what about diagnoses that people need to be familiar with, and maybe how to manage? Any key diagnoses that you that those coming in should be familiar with. Mike, do you want to start off with that one?
Yeah, I mean, I think the bread and butter, obviously, you need to know about shock, and understanding that it's not just, hypotension or low blood pressure, that you need to sort of develop a deeper understanding of what that truly means. And then I think that will sort of lead you into the different causes of shock. And those you sort of need to know. Sepsis, obviously, being probably in the medical ICU, our most common cause. And so I would probably start there, and then hypoxia, hypercarbic, respiratory failure, getting into, what is the difference between those, acute on chronic, causes, treatments. And so I think if you start with shock, sepsis, and respiratory failure, huge topics, and that you can study them forever if you wanted to. Those are probably the big ones I would start with.
Yeah, I agree. And I would hit or kind of emphasize shock a lot, because it's not only shock, it's what kind of shock. Because, of course, you need to be able to at least know what your different classifications are to be able to recognize it and know that the management for each category of shock or class shock is very different. If you give a ton of volume thinking someone's septic, but they're actually an R&B failure, we're in trouble. And so just at least kind of being able to wrap your head around those different classifications. And then we have a decent amount of liver failure patients. And so I would want some folks, again, not the first thing when you're walking in the ICU, but be able to identify acute liver failure versus acute on chronic and what the difference is there, presentation-wise, etiologies, and what you're going to do about it, along with kind of how does that prognostically change what you're doing for them. And GI bleed. You can't be in a MICU without managing a GI bleed. So, so of course you're, shock and respiratory failure, but then those are quite common diagnoses that we run into as well.
Definitely. And Kirsten, I think one of the things that you kind of alluded to, and Mike and I also, we work at a liver transplant center. And, as a person who is maybe starting off your career in a new ICU, or if you're rotating to the ICU, you need to be aware of the type of ICU you're working in. And if you're working in a transplant center, maybe do a little bit more looking up on liver failure, if that is a big thing that is happening at your center. And I have even, when I first started off, my prior job was doing VA ECMO, and I hadn't done that before. And I asked before I even started, hey, can you send me what you think would be important to know about this? Because it's a topic I wasn't familiar with. So even asking before you get there or your first day, those things can be really helpful, because many times, depending on where you are in the country, your diagnoses you might see a lot more of something in that particular area.
Yeah, you're very right. And sometimes, hopefully, you got a little bit of an idea when you interviewed and potentially was able to kind of round for a small amount of time with the team, talk to some of the current employees there and providers there. But that's a really good point. And a good recommendation is do your homework before you show up on day one, if you're able to kind of prep and not be as intimidated, because it is a big transition that first few months.
Kirsten, what about, so we talked about our diagnoses, maybe some articles to start with. Where can people go? What resources do you recommend for somebody who is trying to learn more? Do you have any books or podcasts or websites?
Yeah. I'll start with books, because I know that's kind of not as be with podcasts. They're obviously awesome. Websites are really quick and easy, but I always recommend the ICU book by Marino, just for a good kind of foundational knowledge. Even I know that they just released one. It was the first time they released it in a while. But the pathophysiology in that book is really, really good. That's not going to change. Now, some of the recommendations, of course, if you have an older version, might be different, but that is really, really good for just understanding pathophys. Harrison's Pulmonary Critical Care Medicine textbook is a good one. If you're going to have something kind of tangible And then for a quick reference, in the ICU, the Pocket Medicine book by Mass General. I have the internal medicine one, and I have coffee spilled on it, sheet ribbed, probably because I was so frantically flipping through in the first few years. So I definitely kept that one in my pocket. So for something holding on to, that's what I would recommend. But for also quick reference, just on websites or things like that, I really like the ATS Fellows reading list for a bunch of hallmark kind of trials within pulmonary critical care, being the ATS Society. And then one that's more international is Critical Care Reviews website, and they'll give you updates on when new articles have been released, where they are in their cases, kind of the implications for practice, and keep you updated on a variety of critical care specialties, so not just pulmonary critical care or cardiovascular medicine. So I really like those. Of course, there's Up to Date. New England Journal is great as well. APAP that has great sources as well. So the list goes on, but those are a few that kind of come to mind. What about you, Mike?
Yeah, I think Merino is great. I remember when I was a student, I was on my psych rotation before going to the ICU. And when I had downtime on psych, I was just reading Merino kind of in prep, because I knew I didn't want to do psych. So in preparation for critical care. So I would definitely recommend that, can echo that. There's a book that I was actually just looking up because I forgot the name of it, but it's SCCM, Fundamental Critical Care Support, is another book. It's not, I think, quite as in-depth as Merino, but it presents things in a very digestible sort of factual way. And I think, I don't know if we still do this. We had a period of time where at Leahy, every new hire, we have a copy of it. We just gave them to this and like said, you need to read this cover to cover, basically. And so that is a good resource as well. Talking about like things online, people probably are aware of like the MCRIT blog, and they have the Internet Book of Critical Care. That's like a phenomenal reference that I find myself using still now, 10 years into practice. You have to be, I think, a little bit careful online because sometimes things are a little bit further from the guidelines and people are sort of experimenting a little bit, which is okay, but certainly would want to confirm from more than one place, what I'm looking at is true, is the standard of care and that sort of thing.
Definitely. And I will say it can be hard to learn about everything. And as you guys have alluded to earlier, there's so much within critical care. It can be really difficult, but doing your best to try to stay up on things is really helpful. I don't know if you guys are familiar with the bottom line. That's one thing I like to reference sometimes. They go through new articles and can kind of help focus you in on the data and maybe even give you some ideas on how to analyze what the article is actually showing. So that's definitely one of the ones I like to look at. All right, so kind of our two last topics are going to be focusing on you. Hopefully you've done your reading, you're in the unit, now you're rounding. What about tips and tricks for rounding, maybe working with consultants or different attendings? Kirsten, you want to take that one first?
Sure. I'll kind of start out, I guess, rounding with the attending informal rounds is one thing, but I like to even think about rounding as, what you're doing on your own after you get signed out. So including starting with, all right, I've gotten signed out. These are my patients. Brief chart review. So I think it's important if you can, if there's not a super emergent reason to go directly to bedside, get a little bit of background information. But the caveat I always tell learners is keep it brief. Don't get stuck in the weeds doing a chart review that's like 20 minutes long per patient without ever going and seeing them, because I think that actually causes more anxiety and a little bit more confusion. And so I would start with a brief chart review, at least get top 5 diagnoses as to why they're there, what the plan has been so far, and what changes you might want to make, along with culture data, what antimicrobials are they on, of course, vital signs. But The caveat being, try to time yourself is what I tell new learners, starting with a little bit more grace, as you probably have a lower census assigned to you initially, and then make it as quickly to the bedside as possible. Because at least for me, again, if you get stuck in the weeds in the chart review, I feel like it can make it a little bit more complex in terms of, trying to understand and put it all together. But when I go to the bedside, I'm like, okay, I had a little bit of background knowledge. Now I see the patient. This all makes more sense. And actually, yes, the chart can be overwhelming. Like, wow, this patient's quite sick. Go to the bedside and yes, confirm sick, but I can see them. I know what's going on. I know what their perfusion status looks like. I know what their mental status is. You get great information from the bedside nurses that are there constantly. And that helps put a lot of things in context. So in terms of rounds, those are my recommendations for kind of prior to the formal rounds with the attending is have a system in which you do it that's pretty methodical, but don't get stuck in the weeds. In terms of that chart review, go see the patient, do a really, really good thorough exam. And then once you sit back down, you can kind of put it all in context and get ready for formal rounds. But Mike, I'll let you kind of maybe make some suggestions about formal rounds, because that all is really important, but it varies on where you practice and who you're practicing.
Absolutely. And I'll say, I agree with you. I think going to see the patient earlier, after you you don't want to go into the room blind, but having a little bit of that, why are they here is super important. And the way I think of the physical exam in the ICU is like anything that's attached to the patient counts. So look at the ventilator if they have a breathing tube in. If they have continuous infusions, you should look at those pumps, see what medicines they're on, and have you don't need to know the exact dose, but is it a low, medium, or high dose? And for me, that's part of the physical exam, right? This is something that is physically in contact with your patient. And so it counts. It's physical exam. And so knowing that going in is super important. In terms of formal rounding, it's like a skill. And so it's something that I think has to sort of be developed over time. Something for new people, if you are able to, talking to the more experienced people on the team and say, hey, do you know we're with Dr. Smith today? What is their rounding style? Do they like to know, am I going to read every lab value? Do they just want to know what's abnormal? What is their style? Because obviously attending to attending is really different. And the people who have worked there know that. And so I changed my rounding style based on which attending I'm with. And so being able to ask someone with a little bit more experience, I think is really helpful. Trying to say, be concise, especially with like HPI, talking about things that happened 20 years ago, 30 years ago, are probably not relevant. You can have it in the back of your mind, but necessarily saying it out loud is less important and will sort of bog things down. Trying to avoid words like, this is normal, or it looks okay. You should be, if like the labs are all normal, we say, then, it's unremarkable. Or I looked at the labs, they all seem fine to me. When you say normal, I find it sort of triggers some attendings and preceptors and stuff. And it's like, well, what is normal? What does that mean? And you kind of get yourself into a little bit of, we've all been there, right? So it kind of gets you into a little bit of a hole that way. And I think the most difficult part is obviously, I think, coming up with the plan. So having your problems in the most, life-threatening thing first and kind of going down the list. I think where a lot of people hang up, especially newer learners, is there's a lot of uncertainty because you don't know should I give this person LASIK or should I not? And I don't know what the answer is, even after going all of the data and seeing the patient and that sort of thing. And I sort of have found that I think just making a decision, even if it's wrong during rounds, is probably better than being indecisive. And that seems sort of counterintuitive. I think the reason being is that it sort of prompts a discussion. Because you're going to say something, I think we should give this patient LASIK. And then the question becomes, well, why? And you need to have the why. Because if you're wrong, but you have a good reason, and you could say, well, they've got 4+ edema and their EF is 20%. And so I think that they need LASIK. That person may or may not need LASIK, but at least you thought about it and you have a good reason. And now we're going to talk about it on rounds. So coming up with a decision, realizing that as a learner, that it's okay to be wrong, and you're better off being wrong and having an in-depth discussion about it than saying, I don't really know what this person's food status is, so I don't know what to say. That sort of tells me you didn't really want to think about it. And so I would definitely don't do that. You need to have a plan, and accept that it's probably going to be wrong sometimes. And that's okay. That's why we round, right? That's why there's an attending there and other APPs to help us out.
And to be fair, you get 10 ICU providers in a room. You're not all going to get everybody will play the same thing. So
Nope.
I would almost argue that being wrong is somewhat relative. And but
Absolutely.
it's good to have that discussion so that you can really think through all the things, right? Especially if you're working more medical kind of population and patient, there are so many complexities, and one thing affects another thing, and so there are a million things to consider. And so being wrong, I have found the more I've been in ICU, I feel a bit better sometimes when somebody doesn't agree with me, because I'm like, well, that's their art of medicine. That's the way that they want to handle this issue, and maybe I would handle it differently, and that's okay. And I think that talking about rounding and coming up with a plan also kind of flows into maybe some note writing. And I know it's not necessarily easy to describe how should you write a note in a podcast, but Mike, do you have maybe some tips or in pearls of wisdom for how somebody can write a good note?
Yeah. I think so, especially as a learner, the biggest thing is it's so tempting, and we're all guilty of it, to copy forward the note from yesterday. And I think that's obviously a big mistake. And it kind of comes down to the why part of it. So if you copy forward in your note, this person has sepsis from pneumonia, and I ask you, well, why do you think they have sepsis, and why do you think it's pneumonia? And you don't have a good answer because that was just what you read in the note yesterday, that's not a good thing. And again, it shows me sort of that you're not really thinking about it. So especially when you're starting out, come up with your own problems, your own differential, your own workup, and your own plan, and approach that in the same way every time. And then write your note, and this maybe is sort of not the best way to go about things, but write your note as if you're going to have to read it on like a stand to a jury someday, and have to explain what you're thinking. And so it should have enough detail that, 10 years from now, if you, God forbid, get called into court and you have to remember this, you should remember what you were thinking. And so that level of detail is sort of a very, it's a fine line to find. You don't want to have too much, but certainly not enough. And so enough detail also that someone else reading your note should have a gist of what's been going on with the hospital stay and what's going on today. And they should get that from just your note. They shouldn't have to look back the last 15 progress notes to figure it out. So having your note in a place where it can give you a good synopsis, it's your own plan, assessment and plan, and it's not, just 1,000 imaging studies that are cut and paste from like the chart or something like that. I always have to delete those. Those are like insane.
Sensory overload.
Yeah.
Yeah, no, I agree. Inertia is a powerful thing, and it can be good or it can be bad. But if the plan that it was in place when you inherited a patient, today's a new day. You might actually have new data that they didn't have yesterday that is very applicable, and it maybe should change that plan to a different path, or, changing antibiotics. There's new culture data. So I agree. So own it, make it your own, and try to look at it as, honest with a new, fresh set of eyes, I guess, every day. And then the other recommendation I would have is for the patients that are just coming in where there is still uncertainty. Yes, I can definitively say they're in shock, right? They're on vasopressors, the lactate's 11. But if you're not sure exactly what it's from, I always challenge our learners, don't just tell me shock, tell me secondary to what. And if you're not exactly sure what type of shock it is, tell me what you're doing to work through those differentials. So I always kind of challenge new learners, okay, well, we think it's shock right now. Where differentials include, is it cardiogenic? Is it septic? Is it hypovolemic? And then tell me what you're doing in that plan that's going to help confirm or rule out those things. And I think if you can think of it that way, you're going to have a pretty comprehensive and robust plan, but it also challenges you. Well, what should I be doing if I'm thinking it's septic shock, right? What should I be doing if I'm thinking it's cardiogenic, or obstructive? So I think that's really important. If you're going to give me a diagnosis, then tell me the etiology. And if you're not sure about the etiology, tell me what you're doing to work it up. And that'll help kind of make that plan a bit more comprehensive. And I would say, challenge yourself as well to give true diagnoses, not lab values. So don't tell me leukocytosis as a diagnosis when they're in profound septic shock. Put it all together. And so try to make those true diagnoses, applicable to the patient's care. And, again, what you're going to do about it. I agree with being concise yet thorough in your documentation, because you do want to be able to rely on that if you're asked about it later. But it's also really important as a safety, issue if you're not leaving enough in your plan for other consulting services to understand what your thought process is, or the night team or the day team to understand what you did and why you did it. And so I would look at it as well for communication and then maintaining safety throughout as well.
Yeah, and I think it's okay, sort of what you're saying, to, in your plan, say, they're in shock and they have a white count of 15 and they have a fever. And so I think it's sepsis, but also their troponin is high. And so I'm worried about cardiogenic, and I'm going to get an echo and an EKG and do these things, because oftentimes we're making sort of very big decisions with incomplete data because there's just not time, right? The patient's really sick, and we sort of have to move forward with a plan. And so, but documenting what your available data was at that time and what your thought process was at that time, even if you end up in the wrong spot because you thought about it and you had good reasons to do what you did, and you documented that clearly, then it's probably okay. And then it'll end up getting to the right place.
Thank you. Yeah, definitely. Any final words of wisdom that you guys have? I know we've kind of talked a lot about whether it be attitude and knowledge base and, grounding and no writing. I mean, those it's surely the bread and butter of the ICU. But any final words of wisdom for anybody starting off their career or rotation in the ICU?
Go for it, Mike.
I would say that if you're one of those people that are kind of like us, that you love critical care, then you probably have a good sort of gut instinct about a lot of things, and I would trust that. And there are so many times, and still now in my career, where I've just had that little, spidey sense in the back of your mind, and I think that this is what this is, but I'm just not sure. Maybe I should go back and examine it, or maybe I should order that, or maybe, and there's just like a little piece of doubt in the back of your mind about, am I sure about this? And I would follow that and I would trust it. And it has saved me a lot of times to go back and be like, oh, there is something here. And if there's not, then you reassured yourself and say, oh, okay, I'm sort of on all of this and I've got all the data and I'm going down the right thing. But I think trusting your instincts about, am I on the right path here? Is this person sick or not sick? It is very telling. And then I think sort of switching gears a little bit is you need to sort of cultivate a hobby or interest outside of medicine. And so the ICU and critical care can absolutely be all consuming. It's very physically and emotionally draining, especially as a new learner, super, super overwhelming. And you need to actively carve out time where you're not doing something related to medicine or healthcare, whatever that is. But I've found that that's super, super important. And if you don't have that, it affects your ability to, I think, to practice medicine effectively. And you get sort of cognitive clouding, and decision fatigue and all of the things that we know go with stress. So having, something to do outside of medicine, whatever it is, sports, family, movies, video games, anything, is super important.
Yeah. I would echo that. Agreed. You can't provide really, really good care at the bedside if you haven't taken care of yourself first. And we tell this all the time to our patients' family members, but I would say it is really, really important, as you're alluding to, Mike, not only physically making sure you're recovering in between long days on your feet, but mentally and emotionally, always check in with yourself, have a way to decompress, disconnect. So be mindful of it. The other thing I would ask or would kind of recommend is just never stop asking why. And not in a disrespectful manner or anything like that. But when you continue to ask yourself, well, why are we doing this? Two things happen, in my opinion. You keep digging deeper to try to make sense of what you're seeing in front of you clinically. But it also pushes you to then say, well, what's the data behind this? I mean, we do a lot of things in critical care where there's some good data, but then there's a lot of mixed data or lack thereof. But continuing to ask yourself why will put a lot of things in front of you at the bedside into perspective. But that's where I think you also go to a different kind of level of understanding and being able to truly master some areas of critical care that you see every day and knowing the data behind it. And the last thing I would say is, critical care is very rewarding, but can be stressful. So give yourself some grace, stick with it. There's a lot of good things that we do on a day-to-day basis for the patients and family members, which is great. And that's why you're doing it. So don't be discouraged by the tougher days, and really keep your kind of own health at the center of that so you can keep delivering great care for years to come.
Yeah, the asking why is super important. And I think that there's a lot of tact to that, right? Because sometimes if you're asking an attending or a consulting attending or someone who presumably is kind of an expert, right, knows more than you maybe, say, well, why are we doing this? Or why are we not doing this? Can sometimes rub people the wrong way. And so I always try to frame it of like, so, for my own knowledge, the CT scan showed there's air in the biliary system. And generally, this is a surgical problem and we're not managing this surgically. What is our thought process for this? And sometimes there's a good reason for that. But sometimes it also will prompt them to say, well, wait a minute, let's go look at the guidelines. And we end up looking at this and saying, oh, maybe we aren't going about this the right way. You're right. Or, hey, you're right. 90% of the time, this is a surgical problem. But because of X, Y, and Z in this specific case, we're not doing it this way. And so I think either way, framing it is that like I'm not disagreeing with you, but I want to understand your thought process for this. Sometimes gets you to a better place, sort of, when you say, just like, well, why aren't we operating? Like, why aren't we going to the cath lab? Because people, I think, sort of can get defensive about that. So framing it in the right way.
Well, definitely not what you say, but how you see it is like 95% of life.
Yeah. Yes.
In my opinion. So that's a really good point.
Well, and I think that goes back to what we talked about in the beginning, is having that attitude of humility. And so, especially if you've already displayed that, then when you're saying, okay, can you help me understand this? Because I don't understand. And quite frankly, that is a great way to learn. And as you mentioned, Mike, a great way to, if you're having a different thought, it can maybe either help the consultant rethink the question, or it can help you learn because maybe they have new data to support their thought process that you just don't know. And so I think all the things we talked about are all interconnected. And if you can be humble and asking in a professional way and in a way of like, hey, teach me something, then that can also help you learn. It can be better for the patient, and help everything overall. So it really is all tied together. So those are the questions I have for you guys, and I really appreciate you taking the time to be here and go through this. I really think this is an important thing because as I know both of you are passionate about training kind of the next, I don't know if I want to say generation because I don't want to admit that I'm that old, but the next kind of group of ICU providers. I think I can say that we are all very passionate about doing really good medicine, really evidence-based medicine, and taking care of our patients in a successful way. And so I appreciate your input here, and I hope that this podcast can be helpful for those again, starting off their career or a rotation in the ICU, but also who are doing that training themselves. So thank you very much. For those who are listening, thank you so much for listening to the APOT podcast. Please support us by liking and subscribing to this podcast wherever you're listening from. Don't forget that you can claim CMEs. The link is going to be in the show notes. And so any of these podcasts that you're listening to from APOT, you can actually get CME credit for. If you have interest in being a part of APOT, in being a part of the critical care committee, and directing which podcast we do and the critical care concept that APOT offers, please reach out to info@forumapp.com and definitely get connected that way. So again, thank you so much, and I hope you all have a great day. Bye-bye.